This first session was a challenge round. Challenge because we all had to finish 80 pages of guidelines in 12 minutes. And that was a very interesting task and given to us. And all of us have finished almost in equal time. So any questions from the audience?
Before any question, Dr. Vijan, I have one question for you. What about the bolus? Because that has been tradition that when a patient comes to the casualty, we ask patient to open the mouth and put 2 ticagrelor maybe or clopidogrel, whatever it is. So what is the changes? Because some trials have shown that it may harm. In the Western world, because many patients may go for surgery. In our Indian setup, and rarely a patient who comes for the STEMI or other ACS goes for the surgery, do you still feel bolus should be given to all the patient or it should be given after the angiography?
I think the guidelines are actually very clear. If you're going to use Prasugrel as your antithrombotic of choice, then you should only give it to you after you know the coronary anatomy. They're very clear on that. But in, say, case of STEMI who comes in, and you want to give 2 bolus dose of ticagrelor and 1 aspirin, and they're okay with that. That's not a problem at all for anyone. Even though patients may land up going for surgery, they're okay with that. Whereas with Prasugrel, it's very clear. Only after the anatomy is known. In STEMI and in non-STEMI, in fact, they say don't give them till you know the anatomy. Yeah. Any antiplatelet, don't give till you know the anatomy. So that's another difference in the way we practice. But for us, it's so much easier to say, give this, and get the patient up, which includes a statin in our case, and also heparin or enoxaparin or whatever you want.
Only in chronic stable angina, clopidogrel is preferable compared to.
Yeah, not all patients should be on ticagrelor. The most, Dr. Millens want to say something.
Yeah. So 2 questions actually. One is in the long-term antiplatelet therapy. Now instead of aspirin monotherapy for the little higher ischemic risk patients, is there a role of the more potent P2Y12 inhibitors like Prasugrel or ticagrelor monotherapy? That was one question instead of aspirin. And the second is, sir, regarding patients with STEMI, stable patients who present more than 40 or who are angioed for 48 or 72 hours after the event, and they have a totally occluded artery. Now, for the past several years, the guidelines have continued to recommend that this artery should not be opened unless the patient has ongoing ischemia or hemodynamic instability. Even viability assessment is not recommended, but this is one of the most violated guidelines that we see. People open up these arteries. So I wanted your thoughts on these 2 things.
I'll check the second one up here. Clear. The guidelines are very clear. If you have more than 48 hours following the index myocarditis and the patient is asymptomatic, either from heart failure or angina or ECGs are not changing, do not intervene. They're very clear. And again, like before, they are not recommending viability testing. They say there's no point doing that. It doesn't help. And I think subsequent to that, so many trials have come up which show the viability testing actually doesn't help us.
But that is about the O trial. But apart from this infarct-related single artery, there are other vessels are also involved.
Yes.
Then definitely, so there is a different thing.
Yeah.
Because a lot of residents I can see here, single vessel total infarct-related after 48 hours should not be done because it does not benefit, it may harm. But if it is multi-vessel with the total, then definitely we need some. Madam, your...
And the monotherapy with potent P2Y12 inhibitors.
Pegasus.
Yeah, as per Pegasus trial, post-MI intervention, after 1 year, one can add a low-dose ticagrelor with aspirin. But having a P2Y12 inhibitor like ticagrelor or Prasugrel alone on a long term, I have not come across any study. And actually there is a problem because all the trials have told us up to 12 months. Beyond 12 months, what do we do? But probably beyond 12 months, a de-escalation may help, aspirin and clopidogrel.
Thanks.
I think the data from the Chinese study of acute myocardial infarction, long-term clopidogrel alone without aspirin has shown to be very beneficial, reduces the incidence of recurrent angina and infarction, and that's up to 7 to 8 years. So clearly, single dose 75 milligrams clopidogrel as the lone antiplatelet drug would probably be very good in chronic cases.
So CCS and ACS are different altogether. Clopidogrel and ticagrelor others, and Prasugrel is the most underused medicine. Dr. Bhavesh.
Yeah, hi. So regarding this loading dose for ACS, so most of the time the loading is given as soon as the patient reaches the casualty. At that time, you're not sure whether the patient is going for thrombolysis or for a primary angioplasty. and sometimes we are not sure also whether there is an acute coronary syndrome. So probably it might be prudent to give a 300 milligram clopidogrel rather than ticagrelor. And once the consultant comes in, or once you are sure that you are taking for a primary angioplasty, probably ticagrelor or prasugrel can be added. I think no harm in that. And my question is to Dr. Hetan about elderly people with high systolic blood pressure. And so the difficulty in controlling it, and when you are trying to control the high systolic blood pressure, your diastolic goes down. So can you give us some more idea about how much low diastolic pressure is acceptable, or what should be done about it? Thank you.
Elderly patient, we have to be moderate in controlling the pressure unless you are dealing with associated insult like a coronary artery disease or a stroke or a dementia and like. In that case, you have to be little aggressive. But those who are fit elderly, above 80 years of age, and they have arterial stiffness, the guideline says 160 by 90 should be the upper limit you should accept. And here, if it is not controlled, if the diastolic pressure, you should go once the systolic goal is achieved. Okay. Diastolic, up to 70,
Like
60.
170 by 70.
170 by, ideally this ESC guideline says up to 80 to 90. But that they said if systolic goal is achieved, then only you should focus about the diastolic. But up to 70 you can accept it. Yes. Yeah, they have a wide pulse pressure grade. Like, yeah. Yes. Yeah. In that case, we have to just focus the systolic.
The,
Yeah.
the,
Anemia in
Blood pressure, on blood pressure, yes, maybe.
the danger,
any high output patient will
But-
have a wide pulse.
Bhavesh, the danger of low diastolic pressure is especially for patients with coronary artery disease who have not been revascularized. But patients who have been revascularized or patients with cerebrovascular disease are not hampered by low diastolic pressure. So only the patients who are not revascularized because of the low diastolic filling in coronary arteries.
Most of the times, elderly patients are on centrally acting drugs like clonidine and all. That is not advisable. That
I
is,
think there's a very nice US task force paper on hypertension released last week, which just turns everything over the top. They are recommending higher systolic blood pressures as acceptable in the elderly. I mean, they're talking about 80-year-olds, even about that. But that's-
Akshay.
Hey, Ethan, question
Akshay.
not on the, sorry, sir. No, sir, please go ahead, sir. I'm sorry.
In the chronic coronary syndrome, where does this angina with normal coronary arteries fit in? A lot is being talked about ANCA. But if you remember in the past, we used to have a lot of patients with an angina-like pain and with STT changes. And we used to call it this as a syndrome X. As a matter of fact, from Sion Hospital, myself, Gandhi and Ashwin had published a paper also. We followed up these ladies. Actually, most of them were ladies. If you remember the paper, or I may tell you. And they were followed up for several years. The ultimate outcome was absolutely normal. They lived like any other normal person, but they continued to get that angina-like pain. Now, is this ANCA, as it is called, angina with normal coronary arteries, a true ischemic syndrome, or is it just a functional syndrome? And we actually gave it a terminology, like it's called as a dysmetabolic syndrome also. Of course, then the diabetes and everything came, but we called it as a metabolic syndrome also.
So Western figures give an incidence of almost 50% of angina patients have this kind of disease, and they have classified them into two groups. One is people with microvascular dysfunction due to risk factors, and they have to be treated like coronary artery disease patients. Whereas the other group are the vasospastic angina patients, where there is spasm of the epicardial arteries, where antispasmodics have to be given like calcium channel blockers and nicorandil. But the other group, which has microvascular dysfunction, they have to be treated like coronary artery disease patients. And the long term is very interesting. As you said, we have also found a lot of patients, they do well. They have angina, but they do well. But the Western literature says that they have the same risk, long-term risk as patients with epicardial disease. And they have to be, they have the same incidence of heart failure, etc., etc.
As a matter of fact, we discussed this problem in one of the meetings, international meetings. And the consensus was there that you can prove this is true angina by collecting the blood from the coronary sinus, do a right atrial pacing, and if you find that the lactate level goes up, then it is a true angina, otherwise it is not a true angina. I think this is what the consensus
Yeah,
was.
sir, we had done a study at KM where 100 patients of angina with normal coronary arteries, majority I agree it was a female, and we did a non-invasive nuclear testing like a thallium, and we proved there is a mismatch, perfusion mismatch. And we didn't withdraw the medicines and we continued the anti-anginal and patient did well.
Okay, last two. Dr.
Sir,
Vaibhav?
sir, Akshay sir, just one question directed to one of your slides, which I did not understand. I haven't heard about this. You mentioned about ivabradine being harmful for the treatment of angina in patients with normal LV function. So can you please clarify on that and what is
Yeah,
the
there is a
mechanism?
very recent study, I forget the name of the study, where they studied these patients with angina. Their quality of life improved, but there was harm, there was more mortality in them. So this is very recent, and the guidelines have specifically mentioned this as a class 3 indication for ivabradine.
I'll tell you the reason. Because one of the side effects of ivabradine is atrial fibrillation and Wenckebach block. So I think these are some of the arrhythmogenic effects that we do not, these are called as funny fibers
Yeah,
in
but
sinus node.
Yeah, they have shown more mortality, that was the problem.
So they develop atrial fibrillation, they're likely to die. Yes.
My question is, if a patient is presenting with total occlusion of infarct-related artery after 48 hours and has a TVD and needs bypass, whether surgeon should bypass that vessel or not? 48 hours after MI? Yeah. Should that vessel be bypassed or not? If artery and patient has TVD and goes for bypass surgery. The infarct-related artery which is beyond 48 hours, should it be given a graft or not?
Yeah, I think all surgeons, despite whatever they say, if it's 100%, they will put a graft and come out. Because they have to come off the pump. They are not going to take chances about not. So they will come off, they will put a graft and come off pump. They will not take the chance of not grafting the infarct-related and then
Taking
run
a
a problem.
chance, then why not? It
So
should be.
our question is whether if it's a single occluded artery, more than 40 hours, should we do something for them?
I think some
medical
gray area
treatment would be
exists,
as
that's
well.
what I
You
will say.
don't.
Thank you very much. A wonderful session. Panel, yeah.
Thank you, respected chairpersons and speakers, Dr. Hetan Madam, Akshay Sir, Suresh Sir, and Anil Sir for a great session, very timely session.